All right, so move on to our last speaker of the day. So Zeru is one of our medical students here at Sinai. He's now a third-year student. He completed his Bachelor's of Science in Biochemistry and Molecular Biology at Franklin and Marshall College. He has been very active in the department. If you haven't met him yet, you should seek him out. He's been extremely productive as a student on the research end with mentors, including Dr. Germano, Dr. Chowdhury, Dr. Shrivastava, and others. Today, he's going to talk about a project he worked on with Raj, looking at resident burnout. So Zeru, if you're on, go ahead and share your slides.
Okay. All right. Thank you everyone for having me. Thank you for the kind introduction. And today I'll be speaking about blackouts in surgery, a study of surgical resident workload and burnout. I have no conflicts of interest or disclosures. And this presentation will be based on our recent study that was published on The Surgeon, which has an identical title. So what are black clouds? So you might have come across this term as during medical school, residency, or as an attending. And I went to the literature and grabbed some quotes. So according to some papers, it's defined as somebody who often has more cases, both in terms of number as well as level of difficulty. Others have defined it as a person who brings bad luck or increased workload in a medical setting as identified by themselves or by their colleagues. And others have defined black cloud and white cloud as those who are perceived to have larger or lighter than average workload during call shifts specifically. So a bit more background. There are two studies I want to highlight. The first one was done on pediatric residency interns at Stanford Children's Hospital. And it was a mixed methods study that utilized a survey as well as a database query for notes and orders written during their year. And the outcome was that, as you could see on the graph highlighted on the screen right, as compared to the screen left, there is variability in workload. Some residents tended to work harder on average as compared to the rest of the residency cohort. However, their self-perceived workload intensity did not correlate with their objective workload. So regardless of how they thought they were a black cloud or white cloud, doesn't mean that they're working harder. Another study was done on senior internal medicine residents, and this was done in Vancouver, 2 hospitals. Similar design, mixed methods, and the database was curated just for their consults. And 39% of them believed in adverse effects of the word quiet during call shifts. 45% sort of had a belief that there's something called call karma. However, similar to the previous study, it wasn't associated with any increased overnight workload. And in the table, as you could see, most of the demographic factors did not correlate with their workload intensity, and none of the significant values were less than 0.5. So what is novel in our study? So our study wanted to focus on burnout. So the WHO defines burnout as an occupational phenomenon that was characterized by exhaustion, increased mental distance from one's job, and reduced professional efficacy. And studies have shown that surgical residents' burnout is linked to increased call frequency and self-perceived thoughts of attrition that compromise grit. So in addition to focusing on burnout, we also wanted to see if the prevalence of black cloud perception exists across multiple surgical specialties, because the previous studies were mostly done in non-surgical specialties. So the aim for this study was to explore the associations between black cloud self-perception with both actual workload and burnout. Given the literature, we adopted the null hypothesis in both cases. And for our methods, we went for a survey, Google Form survey with 22 questions. We wanted to keep it short to have a lot of residents respond to this. We limited the subject pool to just PGY2 and PGY3 residents, to the junior residents, because we wanted to control for any sort of variation across different program curriculums across residencies. And we surveyed residents in neurosurgery, ENT, general surgery, vascular, urology, orthopedic surgery, and plastic surgery, all at Sinai. We didn't want to use the 22 question Maslow burnout index. It's a validated metric, but we went for an abridged version in order to boost respondent rate. We asked our subjects how often they felt frustrated, how often they found themselves happy or satisfied with work, how often they found themselves sad or depressed, if they felt any lack of compassion towards patients, coworkers, and family members, and also if they agree with the statement that they had a positive influence on their patients, coworkers, and if they felt their training was heading in the right direction. And we summed up this the scores from these questions into a burnout index score that we used in the study. So for the results, the core demographics, out of a possible 66 respondents, we got 41% who responded to our study, and this was a 62.1 response rate. There were 46.3% of our response were women, which is good as compared to the general distribution of women in surgical residencies. In terms of age, most of our respondents were between 25 to 32. In terms of marital status, most of the subjects were not married or in a domestic partnership. Only one resident reported parental status. In terms of level of exercise frequency, because previous studies have noted that exercise has a protective factor, most residents exercise several times a week or weekly. In terms of level of training, 56.1 were PGY2. And in terms of specialty represented in our cohort, ENTs were the highest in terms of their representation, but it's a larger program as compared to, for example, neurosurgery, which accepts only two residents per year. So for our univariate analysis, where the dependent variable was a black cloud self-perception, we want to see if demographic factors as well as self-reported objective workload factors, such as average number of surgeries during a typical call shift, the highest number of surgeries in a given call shift, or the longest case in a typical call shift, the average time in the OR, the average sleep time during a call shift, as well as pagers and notes written, influenced us a black cloud perception. And as you can see in the highlighted red line, none of these factors were significant and they crossed the slope of zero, including the burnout index score. So there was no influence of the burnout index score on self-perception of being a black cloud. In terms of whether the same sort of demographic variables as well as workload variables influence burnout, we had a different set of results. Being female had a protective effect, so we were less likely to be burnt out, women residents. Residents who are married or in a domestic partnership were less likely to be burnt out as compared to those who are single. Residents in vascular surgery were more likely to be burnt out, and those who have a higher average number of surgeries during a call shift were also more likely to be burnt out based on univariate analysis. So we used otolaryngology as our reference because they had the highest number of respondents when we compared across specialties. So in addition, the black cloud score was also not predictive of burnout. So for multivariable regression, we tried to make up a model that best predicts each dependent variable. And we selected average sleep time, average pagers, and average notes, and none of those predicted black cloud perception. So it doesn't matter if the resident didn't have a lot of pagers or didn't write notes or slept more or less. It did not influence their black cloud perception. In terms of their burnout, we sort of got similar results. The R-square, or the predictive value of this model, was 46%. So 46% of the variability of the data is explained by this model. And women residents were less likely to be burnt out based on the multivariable regression. And same thing with as univariate, those who are in marriage or domestic partnership were less likely to be burnt out. But residents in general surgery and orthopedic surgery were more likely to be burnt out as compared to their other specialties. So to summarize the results, a black cloud self-perception does not equate with a heavier workload, nor does it increase the risk of burnout. However, burnout is less likely in females and those who are in married or domestic partnerships, and those who are doing surgery, orthopedic surgery, have a higher burnout. So when we see the literature on this, this could be due to a random workload variation, the heavier workload, because we asked for both the average amount of workload as well as the superlatives, because we wanted to take into account if there is a certain week where there's a high number of caseload, or it's Friday the 13th, or somebody said quiet during the call shift. So we went for both the average as well as the maximum to account for this. Another explanation given in the literature could be that so from some psychology literature was that people utilize unfounded beliefs to regain control under conditions of uncertainty and stress, and they use this black cloud self-perception to sort of cope with it. And this is also corroborated in another study that stated that residents adjust to higher degree of responsibility, competency expectations, and emotional demands using unfounded perceptions. The study that I highlighted that came from Stanford also mentioned that those with black cloud self-perception might be more anxious than their co-residents and ultimately end up burdening themselves with more unassigned work. They might be inefficient and end up creating more tasks for themselves, or on the other side, they might be highly efficient and are covering for less efficient or inexperienced team members, thereby having a higher workload. In terms of why we saw that burnout differed in females and those with married or domestic partnerships, we had a better proportion, so we could rely on the results much better than previous studies that had underrepresented women. And the main thing I came across, and we report in the paper, was that there's difference in coping mechanism. Women tend to utilize emotionally based coping strategies, while men tend to prefer depersonalization and other ego defense mechanisms, such as minimization and denial of guilt. So coping mechanisms might play a role in the difference across genders. Another thing was that in terms of being married versus single or in domestic partnership, relationships tend to have a positive influence on resident grit. And also that those who are in domestic partnership or marriage or in a long-term relationship may result in having like less detachment and depersonalization as their preferred coping mechanism. So relationships might also influence coping strategies. To explain why we saw higher burnout in gen surg and orthopedic surgery, these might be due to program-specific variation. There might be differences in program residency structure and size as compared to the other residency programs at Sinai. It could be level of interaction and type of interactions they're having with senior surgeons, access to mentorship, and other interaction with staff members. Also, program support for residents through social events, wellness programming, and other supportive components of a given residency program. Another side could be that it could be a subject-specific variation. Subjects who are in gen surg or orthopedic surgery might have a different level of anxiety and depression as compared to the remaining of the cohort. Or they could be undergoing social stressors that result in low resilience and reduced grit outside of their work. The limitations of the study include that this study is a single center study. We used an abridged form of the burnout metric. We limited it to junior residents, so senior residents may or may not be experiencing the same conclusions that we're getting from the study. It's non-longitudinal, so it's just given, it's only a specific time. It was done during the fall. And more residents who are experiencing burnout may not have participated because they don't have the time and they weren't willing to partake in the study. So the conclusions: unfounded perceptions, such as black cloud, persist among junior residents in surgical specialties. The self-perception is not related to heavier workload or higher risk of burnout. Gender and domestic partnership, rather than lower sleep or workload metrics, influence the risk of burnout. And addressing burnout and enhancing satisfaction requires a multidimensional approach that takes into account both physical, intellectual, and emotional well-being of residents. Thank you very much for this opportunity. And this is the team behind this work. And a big shout out to Dr. Schruper, John Durbin, Dr. Kellner, Dr. Shrivastava for their support and mentorship in getting this from the IRB approval phase until the publication. Thank you very much.
Thank you,
Thanks
Zeru.
so much, then. Oh, go ahead, Dr.
Yeah. So I'm going to say a few, Alex, I'll just start by saying, so Zeru, excellent talk. So this is a project really that both Alex Schruper and Zeru had come to me on. And my initial reaction was, I felt like the concept of black cloud itself is perceptional. And, I was concerned about how would we really discuss this in the context of wellness. But then in discussion from both of them, and then really in trying to read myself some of the literature, I think it really does go deep into the concept of how we perceive wellness. We talk about wellness often, and we talk about wellness and burnout, I think in various formats and contexts. But what I think the study was at least beginning to highlight is the self-perception concept of how does one feel, and what is everyone's individual resilience in terms of overcoming that. So much of what we perceive are the narratives we tell ourselves, right? This is very difficult for me. Residency is difficult for me. I tend to be a black cloud, or et cetera, et cetera. And then we start to believe our own narrative. And I think that starts to focus our own coping mechanism. And that's true not just for residency. I think that's true for life in general. So I think even just recognizing the fact that this is a component towards wellness, and recognizing the type of ways that we can help cope with this at every level, not just during your residency. I think it goes all the way to faculty as well, I think is very important. And I think what I also liked about the discussion and the idea of a black cloud too is this almost sense of anxiety that it provokes, right? Because you're on call, you think you're a black cloud, and then there's an anxiety component. So trying to find the impact or the source of the behavior or the interaction that gives you meaning and purpose as a way to treat that call. It's kind of, I know it's not realistic to be excited about taking call. I'm not saying that, but I think maybe viewing it as a challenge or some other way that reframes the context goes a long way in how one copes with it. So I really liked all those concepts, and I think this is an excellent beginning. The study itself has many limitations, but I think this is an excellent beginning to this type of discourse. So very good job.
Thank you.
Hey, Zeru. Just wanted to start by commending you. I hope everyone appreciates how difficult it is for a medical student to get the majority of junior residents at an institution like Sinai to respond to a survey is nothing short of miraculous. So I just wanted to commend you on that. You really hounded the juniors around the hospital for a couple of months, and I really appreciate all the hard work you put into this. This is an incredibly important topic. I know it can be a little smirky to talk about the term of black cloud, but just for perspective, last night we had a CNS Wellness Committee meeting, and the majority of the meeting was actually about this. Lola Chambliss, who's organizing next year's CNS, came and talked about all the initiatives she's doing around this topic, to the point that we're going to reach out nationally to all the residents who are signed up for CNS about these topics. So my question to you is, based on the preliminary results of these studies, where would you focus your attention in terms of trying to identify certain factors that may be predictive of resident burnout and lack of resiliency that we can maybe target on a national level, not just on a single institutional level for residents?
Yeah, I think one of the main takeaways for this study is that it's not the number of pages or the notes that the resident gets to write within a single or on an extended year that end up resulting like the burnout aspect. It might have to deal with the social factors that they are experiencing, but also access to mental health and having access to mentors, having access to somebody they could talk to without fear of like what they disclose. And I think those components being integrated into programs might yield a much higher beneficial effect rather than making sure that the resident sleeps more, which is important, but we did not see that in this study, or that they have less time with the pager.
Great, thank you, and congratulations again.
Zeru, congratulations. I echo Alex's comments. It's very, very hard to have so many people answering to the survey. So this is great work. In the way of limitations, perhaps instead more of those that experience burnout replied. So you kind of implied that maybe less, but it could also be more. So I think it's important that we don't have that data. And in the way of digging into the perception a little bit more, I think it would be interesting to look at ethnicity and race. There are significant differences, same as you already did for gender. There are different coping mechanisms, and there are different support nets that different ethnicities have. So I think it would be interesting. I don't know if the data was collected so that the gender is also there. But if not, Alex, with the CNS project, I think it's very important to ask people to self-identify if they wish, and then see if you can stratify for that. Great paper.
Thank you. We were trying to include race as well as like being a first-gen status as potential sort of demographic factors, but at the end we wanted to limit it to like 2 minutes, and that's why we ended up going for gender versus the other demographic factors. Thank you.
I thought that was beautiful, Zeru, and so sophisticated an analysis discussion. When Dr. Germano told me, hey, you've got to meet this student, he's really something, she was right. One thing that you mentioned in your discussion and your answer to Alex was the importance of mentorship, which I did not see in the paper. In my own experience, my feeling of burnout or lack of burnout has depended heavily on who I was, reporting up to and what I thought they thought of me. Was I doing a good job? And I know that had a big impact at UCSF among the other residents as well. Did you look at that, or is there any way to look at that?
Yeah, we did not directly get to that, but what we asked them in one of the burnout questions was that if they felt that training was heading the right way. That's not directly related to just, we didn't straightforward ask about mentorship, but I think the residents who disagreed or did not agree to a greater extent to that statement are reflective of whether they were feeling that training was heading the right way. This might be a bit speculation, but residents who have good mentorship and they're feeling that they're heading in the right direction would have responded more favorably to that question. In the discussion, the paper I cited, they mentioned that residents, they specifically asked them about mentorship. And in that paper, they mentioned that residents who felt that they had easier access to mentors at their institution and had mentors they could discuss both their career trajectory with, had lesser response in terms of burnout.
You hear discussion of malignant programs, and you hear rumors, or it's reported on social media where there are periods within certain programs where there's a lot of unhappiness. And that may be something that could come out from a multi-institutional study. Alex, if you're going to do something national, I have a feeling that there's a certain validity to the concept of the tone of a program, and that has something to do with esprit de corps.
That's a great point, Dr. Barrison. That's the next step, is to expand this into a multi-institutional study. And part of the metrics we're going to look at is perceived perception of programs on the malignant to benign spectrum, and then how closely that correlates with different factors that Zeru has elucidated from this initial study. So that's kind of the next step, and to see if there are certain predictive factors that makes programs more known as malignant or allow them to gain this reputation. So that would kind of be the way we would scale this.
The other thing that is of interest to me is the impact of the 360 component of the evaluation, in which the residents they get to and are asked to provide the feedback. As faculty, we have learned an enormous amount from Ray's program, in which we get graded by you guys on the 5 categories in education. The comments that you write, the grades that we get, those have had a big impact, even though some of you think it may not have had as big as you would like, but it has had an impact. And I don't know if that's something that can be investigated.
I feel like this speaks
So good.
opportunity for studying residency education as almost like the multi-omics of residency education, where you just take every single factor that's different about a program and put them all together, and you try to find out, use different ways of analyzing all of them in one piece to see what affects burnout, what affects quality of education. I think this can get extremely complex with all the variables among the different programs.
And the personal factor that Dr. Srivastava mentioned is very important. So I think his comments are right on. That is really up to us, each of us, to kind of have that perception and how to use that perception and to keep on going. So we can go back and forth between, putting a lot of weight onto the program, the mentors, this and that and the other, but ultimately we also, each of us on our shoulders has a lot of weight. And I think that that's a beautiful comment that Dr. Srivastava made at the very beginning.
Thank you, Isabel. I think one of the things that I've seen, at least in our own residency, if I can, make an observation, is in every residency, there's periods in training that are more challenging than others, right? I mean, in our own residency, being the Elmhurst chief resident is challenging. It's there's a lot of work involved. There's obviously the trauma. There is the continual aspect of what is not anticipated, right? As because of the nature of being the Elmhurst chief, unlike a more elective, maybe let's say program where the cases and the frequency, Elmhurst can turn on itself, as we all know, in a period of a week or so. So I think it's also that too. And I think part of what I've noticed is if you can help identify that aspects of things that are going to change, or that may be different, I think that's a coping mechanism as well too, because there will be times, if you're a junior resident on the Red Service in our program, that's a challenging rotation as a junior resident. And we all acknowledge that, we all identify it, we know it. And I think we and myself as program director can start to think about ways to help residents and training for that type of coping mechanism too, to try to think about or anticipate or structure ways to help alleviate some of that as well, because it's clearly there, it's identified, we all know it. And then so what are the challenges and what are the ways we can help identify to reduce the stress component for something like that? So I think there's a lot of ways we could program that as well. And, I think this is the beginning of that kind of dialogue.
Thanks a lot, Zeru. I thought that was really, really awesome to see a medical student take this to that level of sophistication. And just wanted to ask, did people comment on the transiency of being a black cloud? Is it something that you're kind of stamped with for a long period of time, or are people going in and out of black cloud periods? And I'm interested to hear from the residents. I do hear the term black cloud kind of maybe once a week or so. And so I'm kind of curious what that means nowadays. And is it something that's on and off, or is it kind of a permanent state?
Yeah, so the papers I've seen so far, for our study, what we asked them was, we asked them to rate themselves as a black cloud to a white cloud. So we said 1 to 5, and unsurprisingly, a lot of them, like 70%, went for 3. So they went for the midline. But when we asked them, as compared to their co-residents, we saw some fluctuation. Based on the literature, I did not see any cases of transiency, but it's more like a label, and they get labeled as either white cloud and black cloud. And some studies have even said that it influences self-esteem and how they carry themselves as they progress through residency. That's what I found.
What do you guys think, residents? Maybe Halima, I see some smiling. I know you're on Red Service, so Red Service might provide a cloud of itself.
I do think that once a person is labeled as a black cloud, it is a persistent thing. It doesn't fluctuate during residency. And I think I can have Ray weigh in on that as well. But jokes apart, I think it's fleeting periods of when, there are times when you're on certain services that you're busy and it might be counted as a black cloud, and then there are times when you're not. So I do believe that having mentorship in both from the attendings but also from their co-residents and chiefs is very helpful in getting through periods of burnout as well as increased workload.
Yeah, I would say like sometimes it does persist. Like I still kept a I still kept a text from Robbie from when I was PGY2 advising me to go cleanse myself with a ritual because we just had like a really terrible night together with like 10 surgical consults. But yeah, I would say sometimes there's fluctuations and good and bad, but like for some people unfortunately it persists.
Yeah, it's kind of an interesting factor because it's, at the core, it's completely random. It really doesn't essentially have anything to do with the resident in any way. But I guess, if it does, as Zeru's pointing out, affect kind of self-esteem down the road, it seems like something we should kind of think about, how do you delabel from being a black cloud?
I think also the concept that it can correlate with burnout could also make it a powerful tool for screening for burnout. Self-perception of black cloud status could almost be part of like a burnout screening, the burnout screening tools that exist, if there's a strong enough correlation.
Yep.
And Alex and Zeru, moving forward, one more idea that just came to mind is the role of pets. So not necessarily everyone has a domestic partnership, but a lot of people have pets, and we do believe in pet therapy. We bring them in for our patients. So I think it'll be interesting moving forward to see if there is a correlation with that as well.
And if there is, what kind of pet is best?
No, that we already know the answer. No, I'm kidding. Yeah, very interesting. A lot of different layers. Fantastic.
That was a great conversation, a great discussion, Zeru. You should be very proud of the work you're doing. That's wonderful. Thank you.
Thank you very much, everybody, for the kind words.
Peter, is that the last thing for this morning?
Yeah, that's it for today. If there are no other comments or announcements, we'll adjourn a little early.
Okay, great. Thanks, everyone.